host, Dr. Jay Griffith, Associate Clinical Professor of Psychiatry at ETSU and a member of the Mental Health Clinic staff at VA Medical Center. Dr. Griffith has a bachelor's degree from the University of North Carolina in zoology and attended medical school also at the University of North Carolina. He went on to complete his residency training at the University of Colorado in Denver and then was a psychopharmacology fellow, hence his interest in these psychopharmacologic topics, and he functions as our psychopharmacology coordinator in the residency training program in ETSU. So with those, I give you Dr. Griffith.
Good morning. Is this coming through? How about now? Is that more clear? Yes? No? Thumbs up. Okay. So the title for today is Benzodiazepine Pharmacotherapy, Current Trends and Controversies. I have nothing to declare. Now, I moved out here with the family about 4 years ago, and we were entranced by the nature of the area. The red buds of spring, the verdant hills of summer, and the amazing falls. Truly, it was as Marcella the shepherdess says in Don Quixote, the limits of my desires are these mountains, and if they go beyond here, it is to contemplate the beauty of heaven and the steps whereby the soul travels its first home. How uplifting, pastoral. And then I went to work. Now, I like my job very well, but I was in for a bit of a surprise because I moved here from Denver and never had I seen such quantities of benzodiazepines, and in particular Alprazolam. To put it in perspective, in the year I practiced before I moved out here, I saw one prescription for Alprazolam. So quite a difference. And also the expectations on the part of the patients who presented not only knowing that they required a benzodiazepine for their issue, but they could provide me with the name of the benzo that they needed and the proposed dose. So this is quite a contrast from what I was accustomed to. And there were variations on a benzodiazepine theme in that I learned that the SSRIs I had been prescribing were not nerve pills as I had thought, that only benzodiazepines would meet that. And also, too, I heard many different variants on, it's spelled with an X, but it sounds like a Xanax, as the drug was introduced to me. Now, my colleague said, Jay, you have to realize that you're in the Appalachian, and there is a history of sedatives and downers that goes way, way back. Here we see a still from long ago for moonshine. And here we see from a shot from the Johnson City newspaper of bootleg whiskey being poured down a drain. And from what I can tell, the history is accurate that NASCAR really did get its start from bootleg whiskey and such, the running of the alcohol. This is an editorial from what was then called the Johnson City Staff News, a local newspaper from 1926, lamenting the influence that dope peddlers and liquor providers were having on the community and the rising crime rate. So it has been a long-standing issue, the downers and such. But I didn't have the benefit of this map 4 years ago. This map only came out a couple months ago from the CDC. And in it, we see the prescribing rate per 100 persons for benzodiazepines in the U.S. And you see Tennessee here, and we're in the upper quartile. We rank third in the United States in Tennessee, whereas Colorado, where I moved from, has half the rate. It's in the lowest quartile. So that would have explained to me why I was surprised. I would have gone into it more aware. What I did do, though, is I went back and I looked at the literature related to benzodiazepines and began giving talks, CME talks, about benzodiazepines. Of course, the benzodiazepines were synthesized and released in the late 50s, the early 60s. Chlordiazepoxide, Librium, diazepam. And to put this in perspective, around this time, the DSM-1 and 2, which were really psychodynamically oriented, based a lot on Freud's anxiety neurosis circa 1895, really held favor. And many psychiatrists adhered to the psychodynamic views and the diagnoses. That's what we went off of in those DSMs. And they favored insight over medications as primary interventions. During that time, in contrast, benzodiazepine prescribing patterns, when I saw this, I had to get other references to satisfy myself this is accurate. From 69 to 82, diazepam was the most prescribed medication in America. And in 1978, there were 2.3 billion tablets sold. So this is a cartoon from around that era. Here we see a gentleman in a posh restaurant with his sommelier, and his wife is flicking 3 pills into his hand as he says to the sommelier, "What wine do you recommend with Valium?" Teaching point for our medical students, 0. No wine with Valium. They already knew that. So in this op-ed written by Hennig in the New York Times a couple years ago, she summarizes some of these patterns. And this is about an ad from Roche in the early days. A whole new world of anxiety read an early Roche ad for Librium. It featured a young woman with an armload of books heading off to college. Her newly stimulated intellectual curiosity may make her more sensitive to and apprehensive about unstable national and world conditions. The argument being that she would be better off if she went off to school with a prescription of Librium. The writer goes on to say, this reminds us of a phenomenon that's become so common we no longer even think of it as weird. The oxymoronic attainment, through using drugs to make you feel more like yourself, of an artificially induced normal. So now we see multiple tensions at play. We see the drug companies producing the drug. We see the psychiatry viewpoint at that time. And we see this proposed new normal. Into this walked Gerald Clairman. And Gerald Clairman was really a grand old guy of psychiatry. Many of us read his papers during training. I think he started out, he was married to Myrna Weissman. I think he started out as an analyst, I believe. I think she was also. And he's credited with developing interpersonal psychotherapy. Yeah, so he was a good thinker about our field. And he wrote this for the Hastings Center report on ethics. When new drugs clash with old ideas, psychotropic hedonism versus pharmacological Calvinism. They have such a great ring. The hedonist believed anxiety is a greater evil than benzodiazepines, whereas the pharmacological Calvinists thought anxiety is less problematic than benzodiazepines. So you really had a divide amongst practitioners. He goes on to say, especially among psychoanalysts and other therapists, there is the view that any drug use is a crutch and that the best way to cure schizophrenia, neurosis, depression is through psychotherapeutic means using verbal insight. He also says, in large part, the motivations of the pharmaceutical industries are economic, extending the rationale of drug use to include relief of minor symptoms related to emotional stresses that go with industrialized society. So already at this point, as we're working our way up into the decades, we have the influence of a local culture where we are practicing, national trends, the Calvinism, hedonism, the oxymoronic attainment, and the free market bearing down upon us, seeking to influence. But jumping up to the present time, the number one psychotropic agent in the U.S. is Alprazolam, with 49 million prescriptions, followed by Zolpidem. Only a little bit later do we see our most frequently prescribed antidepressants, sertraline and citalopram. Now, this isn't just in the U.S. As in dose equivalents, Alprazolam is the most manufactured benzodiazepine in the world. So it's fitting that it's written about, and this was on the cover of New York Magazine a couple years ago, written by Lisa Miller, many different subtitles, Xanax, a love story, listening to Xanax, how America learned to stop worrying about worrying and pop its pills instead. And she says that if the 90s were the era of listening to Prozac, this is the decade of listening to Xanax. Now, she goes into it, and it's an article worth reading, but I picked up some of the email responses because I think they highlight some of the current thinking in this country. This is one responder. I believe benzos to be amazing, not so much for anxiety, but I think a once-a-week benzo pop is a very healthy thing. It would help relax your muscles and get rid of tension and stress. Another writer responds, Xanax is such a dangerous thing that it should be taken off the market. Highly addictive, short-acting, causes rebound anxiety. You'll wind up using Xanax to squelch its withdrawal. These are two very... So we see here this pendulum swinging. Okay? This is the pendulum choir that practices out of Switzerland. You see the pendulum swinging to one side, to one extreme, and then swinging to the other side. But this response strikes me as sort of more middle ground. This is a mom, a career person, who says, I'm on an SSRI, but I've been taking Xanax for 25 years. It's helped me function. I don't get high from it. And if you've never experienced panic attacks, then you ought not judge. And that's kind of where I'll be coming from for the remainder of this talk. Now, with that preamble, I'm going to go very briefly through pharmacology, just some high points. And this is by no means a primer on how to handle benzodiazepines. Just want to hit some notable parts. And if people have comments, they'd be most welcome. Of course, when we're using benzodiazepines, we're increasing the effects of GABA, the main inhibitory neurotransmitter in the CNS. And this is just a cartoon of the GABA-A receptor, where GABA binds, as do benzodiazepines, barbiturates, and other agents. They facilitate an increase of chloride influx into the cell and a hyperpolarization or decrease in activity. Now, before we go more into benzodiazepines, just want to contrast this with barbiturates, which were the leading sedatives of that era. And it's striking to me that we're actually in the 150th anniversary year of the synthesis of barbiturates, first made in 1864. They were widely abused on the street. They too bind the GABA-A receptor like benzodiazepines, but they also affect glutamate and neurotransmitter release as well. Unfortunately, at higher doses, it's said in the pharm text, can open the GABA-A channel, letting chloride in independent of benzodiazepines. And so therefore, no tolerance appears to develop to the level at which lethal toxicity will occur. And many well-known folks were found deceased with barbiturates in their system. Marilyn Monroe, Judy Garland. I think Judy Garland, the barbiturate found in her system was Seconal. But many, many more people who were not famous met their demise through mistakes or mishandling of barbiturates. Meprobamate came out in the 1950s and was so popular it became known as executive Excedrin. And it's noted here in part because it shows up, it's a soma metabolite. And soma in its own right, used as a muscle relaxer, is sought after. It's very popular with substance users. Now, compared to the earlier sedatives that were available, a wider therapeutic index and effective in anxiety. Benzodiazepines are allosteric modulators, meaning that they have to be there with GABA in order to show their effect. The GABA-A receptor is pentameric, and I'll show you more about that in a moment, having five protein subunits and many different types. It's generally said that it's the alpha subunit that dictates the effects in the CNS. And here we see a cartoon of that. We see the GABA neuron here with the release of GABA to the GABA-A receptor. If you slice that receptor here and look on end, you see the sites and you see these subunits, beta, gamma, alpha, beta again. And this to me is a beautiful thing. This is an electron micrograph of that section. And here you can see the protein subunits and the chloride ion pore right in the center. And then a cartoon that shows what those might be, again, alpha 1s, beta 2, and gamma. Now, diazepam is called a 1,4-benzodiazepine, and this will matter later. 1 position and 4 position, because that's where the nitrogens are. And by substituting the R1, you can increase the potency. For example, Alprazolam has a ring attached to that site, and it's more potent than diazepam. Benzodiazepine effects, including for sleep, anxiolytic, they're muscle relaxants, and anti-seizure. This is a table just to make a couple points. And I bet if I queried people in the room who've been handling these for a long time, we would get different views. This is the one that I'll put forth today in terms of equivalent dose. Some texts say that Alprazolam is twice as potent as clonazepam, but they're both highly potent agents. They're more potent for sure than diazepam. Lorazepam sits in the middle. Most of these agents are metabolized through 3A4. There are some exceptions, and lorazepam is one, and that's why we use it for people who have liver problems, liver disease, because we don't have to rely on oxidation, so it's a safer drug. The half-lives vary greatly. Alprazolam has a very short half-life, as observed by the person who responded to that Xanax article. And then drugs like diazepam have a very long half-life. In the elderly, the metabolite of diazepam, desmethyldiazepam, can have a half-life of 200 hours in some cases. So you could be 1,000 hours before you're hitting 90% of the steady state. And you go 5 half-lives out. And then bear in mind, in fact, I still recall very clearly my psychopharm lecture from medical school where the seasoned professor got up and said, "Do not ever give diazepam to an elderly person." That was law, or he thought. Now, this is just something you can keep in your mind for fun as I go through the talk. This is about lipophilicity. When administered IV as a single dose, which agent has a longer duration of effect? Again, as a single dose, lorazepam or diazepam? You can talk about it at the end if there's interest. So one thing to note is, actually a member of the audience, Tom Stoss, who's sitting over here, said, make sure you put this interaction in, and he was quite right. And that is that fluoxetine really can increase alprazolam levels. And the studies that have been done actually were done only over 4 days. And norfluoxetine builds up later, and it's the major inhibitor of alprazolam clearance. So theoretically, you can see those levels keep climbing up and go above a 30% increase that they found in this study. In terms of abuse and misuse, I don't know if you'd get this past an IRB today, but the authors here actually rounded up substance users, brought them in the lab and gave them a bunch of different doses of different benzodiazepines and asked them for what was the best high. I don't know if that passed today. But anyway, they did find a statistically significant difference in the top 3 versus the rest of them listed. And they're the ones that we usually think about in terms of substance use. Now, just to note, one of the side effects about respiratory effects, they inhibit the response to CO2 and decrease upper airway muscle tone. So it is said that they can convert snoring into sleep apnea and sleep apnea into more severe sleep apnea. And the FDA lists them on the website as contraindicated in people who experience sleep apnea. Now, Dr. Lader is from Great Britain, and I love reading his work. And by the title, you would probably guess he's not a great fan of long-term benzodiazepines. And when I say that, that's a vast understatement. But he does really nice reviews, and he did some of the original work of CT scanning back in the 70s with benzodiazepines. So he's very knowledgeable. He rightly points out that they are associated with more accidents, falls in the elderly, increased risk of MBAs, and of course behavior problems, disinhibition in those who are subject to losing control, such as in borderline personality disorder. He also notes, and he has a lot of nice references in this article. I recommend obtaining it and looking at it and looking at some of the references. These are just a few of the examples. So some people have been evaluated on neuropsychological tests and then followed out as they stayed on a benzodiazepine for months or years. And basically they show that these deficits like repetitive tasks, attention, episodic memory, that these things continue, these deficits continue as the person stays on the benzodiazepine. And he makes the point that in some studies, it's suggested that it can take up to 6 months of being off the benzodiazepine before these problems improve. Now, this talk would be incomplete without mentioning this recent study. And there have been several studies in recent years showing an association between benzodiazepine and dementia. And so, you know, there's a debate that I've been following out here in terms of, you know, how much can you say with this type of study and so on. But there clearly is an association. And to my mind, when you think about even in normal controls or folks who do not have dementia or have good cognition, showing those kind of defects over months to years, that clearly has to be factored in. So there's a signal here. We don't have it perfectly separated out yet. And you do have to factor in also, you know, you may have seen, I haven't read it yet, but I've just seen it in the news the last couple days, the study that came through showing that high levels of anxiety are related to dementia risk in females. So you have to factor all this in. What I'm arguing for today is a careful use of these agents under certain circumstances. And we'll go more into that. Now let's talk about benzodiazepine use disorders. This is just a partial graph going up through 2011. We know that in Tennessee we have a major problem where drug overdose surpasses deaths through motor vehicle accidents. And unfortunately, since this graph came out in 2011, this has continued to go up every year. So it's still progressing, even with some of the interventions which have recently been instituted. This is a graph, we're going back to that. This is our benzodiazepine graph we looked at earlier, where Tennessee was in the upper quartile for benzodiazepine prescribing. This is just for opiates overall in the U.S. We're in the upper quartile. This is for long-acting opiates. We're in the upper quartile. This is for high doses of opiates. We're in the upper quartile. We share the distinction with West Virginia as being the only 2 states in the country that are in the upper quartile for all of these measures from the CDC. So we have a lot of opiates and we have a lot of benzodiazepines. Now, this is a Drug Abuse Warning Network, the DAWN study, from 2009, where they looked at emergency department visits related to non-medical use of agents. There were over 1 million events. Benzodiazepines were in the picture a third of the time. That doesn't mean it's the sole agent that brought the person to the ER. It just means that they were in the person's system. They were playing a role. And here we see a DAWN report that, again, just came out a couple months ago, and we can see the climb of Alprazolam in these events in coming to the ER. Now, 3 years ago, these graphs were not available. And I saw some old literature, though, showing adverse events and people in ERs with these, but I thought, well, what's going on here? Because, you know, benzodiazepines, generally speaking, are not sought after as substances of abuse as much as, say, opiates or cocaine and such. And yet they're showing up in the ER all the time. And there have been studies done, one comparing by Griffith and Wolf a few years back, in terms of preference after giving it to substance users. Did they like the benzo or did they like the barbiturate better? And they almost always pick barbiturate. So I had wondered what's going on here. And this really explains it. When you look at these adverse events that bring people to the ER for non-medical use, only 19% of the time was Alprazolam the sole drug. 81% of the time it was in combination with 1, 2, 3, or more drugs. And that's what's going on. They're being used in combination with substances of abuse or misuse. Now, this is just Tennessee. A report out this year to the General Assembly. We see that 5 of the 8 most prescribed agents are either benzos or a Z drug of controlled substance in the state of Tennessee. In fact, the combination of hydrocodone, oxycodone, and alprazolam in law enforcement, they don't even list the drugs, they just call it the cocktail. That's how commonly this occurs in Tennessee. This is from the Tennessee Drug Diversion Task Force website. So why might people obtain benzodiazepines? And there are many, many reasons. But there are 3 I'll note today. One would be to enhance other drug effects, which, given the data, looks pretty likely. One would be for profit. And then to mitigate opioid withdrawal. Now, having looked at the literature on this, and I'll show a paper in a moment about number 3, people do use them to mitigate withdrawal. But that is not the main reason why they do. And I had thought all along that they were using them for that purpose. Opioid users were getting a hold of benzos to stave off withdrawal. And then I began interviewing my patients in buprenorphine clinic, and after they finished laughing at me, one of them literally laughed and said, "Oh, no," and then he saved face for me a little bit. He said, "I have done that before, and they can be helpful." He said, "But that's not the reason." And so we have this paper from 2012 about the combination use. And the authors note they had to come to the conclusion that co-abuse of these agents is ubiquitous around the world. It's primarily recreational. It's for intoxication or high, and in doses that exceed the therapeutic range. Now, I want to talk about nodding a little bit. Are people in the audience familiar with that? About going after the nod? Raise of hands, if you will. Okay, so a fair amount of people, but some people nod. For the purpose of this talk, I just made this definition: a dreamlike state of euphoria induced by opioids, often in combination with benzodiazepines. This is off of a blog. And did I get an education about psychopharmacology of abuse by going through these blogs? Because they are amazing. People can tell you how much hydrocodone to put with alprazolam when you're drug naive, and so on and so forth. They're amazing. This person wrote, "Nodding is just the euphoric dreamlike state where all your problems disappear, and it almost feels slightly psychedelic. I often have very detailed hallucinations. People who use lower level opiates like hydrocodone probably aren't used to the nod. So once you get used to it, I'm sure you'll love it, especially with stronger opiates like oxymorphone." So people pursue this with opiates. However, as this mom noted on an interview in NPR this past April, she said, "I loved the rush initially, but then I started to enjoy the feeling of contentment." A lot of people call it the nod. That stops happening with just opiates. So to get that nod back, I had to add in benzodiazepines. This is from an inpatient admission at the VA a couple months ago when I interviewed on Saturday morning. He had come in requesting opioid detox overnight. He'd been consuming up to 600 morphine equivalents, a lot of it hydromorphone daily. But he said after a while he couldn't get the nod. He couldn't get back into that state. So he started using what he called the high-potency benzodiazepines, clonazepam and alprazolam, up to 5 milligrams a day to regain the nod. And I asked him, I said, "It seems to me like you're getting in that state and you like that prolonged state of euphoria, but the next stage might be breathing cessation. You might die." And he said, "That's why I'm here." He said, "Because 2 of my friends died from just that attempt, and I think I'm going to be next." So I came in to get detoxed. So obviously an issue of great concern. So that's the reason why people might combine it. Now, unfortunately, more and more people are combining it, benzodiazepines with buprenorphine. And if buprenorphine does have a protective ceiling effect on respiratory depression, benzodiazepines added on appears to take away that benefit. And in France, for example, greater than 50% of people who are prescribed buprenorphine for abstinence who then get illicit benzodiazepines to add on. And another thing to note is that depending upon the study, between 20% to 50% of people who were opioid dependent who came in for detox were also benzodiazepine dependent, which really highlights the wisdom of considering using benzodiazepines for withdrawal when people are admitted inpatient. Now, having to do with for-profit, these are just some ranges of prices, you know. So if you're really conservative, and one of my patients told me recently, a milligram, $2 for a milligram of Alprazolam sounds like a pretty reasonable deal, but people do pay more. You could pick up a sizable amount of money per month if you wanted to sell them. $240 up to $480, that would make a car payment, obviously. Or you could buy a high-tech Austrian motorcycle like a KTM or whatever else you are interested in. And Dr. Littman, in his presentation last spring brought up streetrx.com, and I've been using it ever since. This is an amazing website because it actually has a map, and it's available for 7 different countries. And you can go in and you can click. You can go into Johnson City. This is for people who are purchasing drugs illicitly. And it'll say, did you get a good deal? And you can put in the drug and the formulation and the price per unit, and you'll find out whether or not you got a good deal. So, very ingenious. Concerning, but very ingenious. Now, what are the sources of benzodiazepines? We know that most drugs are obtained through diversion, but benzodiazepines, in this study, are the most frequently sold controlled prescription, with 89% of the sites not requiring prescriptions at all in order to deliver. And I'd been hearing about this for years, and I thought, yeah, that may be true, but maybe it's hype, because if this were the case, then certainly the DEA would have acted on this issue. And they did. This July, they indicted FedEx on this issue. And you may think, well, why would they go after the company that's delivering the agent? And this is why. FedEx's couriers in Kentucky, Tennessee, and Virginia expressed safety concerns that were circulated to the higher-ups at FedEx that they were being intercepted out on the road. They were being told to deliver to a non-existent address, and then they were being stopped out on the road and threatened with harm if they didn't turn over the pills. And apparently this went on, and upper-level management in FedEx didn't address it. They charged them. So they are going after it, and it is a real issue. Now, this is a paper, there aren't that many, and when they did this review, they have almost 200 references, Pasternak and Mueller, about 14 years ago. When they did this review, they said the literature is scant, but in their review, they were not able to show that people who had been sober for an extended period of time and were in recovery would relapse into substance use if prescribed benzodiazepines. They said that in the non-abusing, substance abusing group, the risk seems very low. They indicated that the biggest risk to watch out for are those with a history of untreated substance use or any suspicions of that. Opioid benzodiazepine co-prescribing. I just want to take a quick survey. What percentage in terms of people on chronic opioids for non-malignant pain, okay, what percentage do you think are on benzodiazepines also? Sir? Over 60%? Others? Okay. 30? Okay. So actually, y'all are in the range. The rate is between 20 and 50% of the studies that have reported thus far, which y'all are obviously more perceptive than me, because when I saw even 30 or 40%, I was stunned. because it's fraught with so many potential issues in putting these agents together. And the author here, Dabsha, in Pain Medicine last year, noted that with the advent of pain being called the fifth vital sign, there was quite a pressure on primary care practitioners to use opioids for chronic pain. And in fact, it's a satisfaction metric by which they're evaluated in their positions. And it's also noted that about 30% of chronic pain patients have a diagnosable anxiety disorder. And benzos have long been used as muscle relaxants, but the rate is 20 to 50%. Now, there isn't much literature in this area yet, and mostly the journal was making a call for further studies into this issue. But they did generate some opinions, noting, as probably all of us would believe, that if they're to be co-administered, it should be, both of the drugs should be at the lowest possible dose for the shortest time. Yeah. And other authors in that journal commented about this, and they listed near absolute contraindications to prescribing these agents together, which were active misuse, abuse, or addiction substances. To my mind, that's an absolute contraindication. I don't see that as a relative. That's an absolute. So far I've gone through and have come up with a lot of different, it's all in the literature, a lot of different factors that might influence our minds as we think to handle or implement the use of benzodiazepines. From local culture, Calvinism, hedonism, the free market pressures, drug interactions, misuse, and the oxymoronic attainment of a new normal. And so it's kind of messy because before we at least had a nice pendulum. And I like symmetry, or at least I like things organized. And now this is kind of a mess. But as mental health specialists, we've been trained to use self-awareness, to monitor our own internal pendulums, and then weigh all these things with social and professional trends so as to make a balanced decision and hopefully a safe and wise decision when we handle pharmacologic agents. And so this is what we're really trying to do. We're trying to parse things out. We're trying to separate them out in a meaningful way. And this is my soapbox slide. And I'll get through it, and then I'll cease and desist with my opinion about this. We all know that DSM-5 disorders, they require, somewhere in every disorder, you're going to see clinically significant distress, which just has to be really severe, and I would say, and impairment in role function in some area. So you have symptoms. You go into an office, and you say, what are your symptoms? But then there has to be something else going on. For example, if a patient comes in and says, I've been having terrible panic attacks, and I know I need a benzodiazepine. Well, when did it last out? Well, I was watching TV, and then out of the blue, you're thinking, well, it sounds like panic disorder. And then you ask them, so that happened, and it's awful, and what did you do? And they say, well, I switched to ESPN. If they're that calm and they're enjoying TV or something like that, that's not a panic attack, And so when we get these, we want to see some kind of negative influence on the person. And so, to my mind, we don't really treat anxiety, nor did we treat pain per se. We actually treat, and then we monitor for dysfunction or impairment. And that then we make a treatment plan with the patient's goals and then track this out to see if they're improving. Having sat on pain teams and working in the pain area, that was always a part when it was handled at the Denver VA where they would come up with the goals of treatment and then they would reevaluate it over time. If the person was not able to carry out more activities or didn't see benefit or if their mood began to slip, they were tapered off the agent. Now, I won't go through all of the disorders where they might be used, but I'll focus a little more on panic disorder for illustrative purposes. In the old literature, there are studies that support this type of ratio for getting significant improvement of panic attacks. This is going back about 20, 25 years ago. Clonazepam, Alprazolam, and Lorazepam in those doses. Now, Schweitzer, who did a lot of these studies, opined later on, he did a lot of the original ones where they went to 5 or 6 milligrams of Alprazolam. But later on, he was able to show really good effect just with 3 a day. And he said, you know, the old studies seem to have pushed these agents up aggressively and rapidly. And he thought maybe that 3 a day was adequate, actually. There is another study that he did, his group. And in this study, this is one of the few studies that actually goes out for 6 months. And they randomized people to either imipramine or Alprazolam at sizable Alprazolam doses. But they were able to show that 6 months out, there were not major problems with side effects that they measured. And on either Alprazolam or imipramine, people were panic-free 6 months out. So that's about the longest term study from years back when the benzodiazepines became available. This is just to make the point. This is a meta-analysis from 2011. There's been a controversy about, are the higher potency benzodiazepines better for panic disorder? And I'm on listservs, and some of the really experienced researchers insist that there is a difference, that the higher potencies are better for panic disorder. But in this meta-analysis, they were unable to show that Alprazolam was superior to other benzodiazepines in panic disorder. One thing that the APA textbook of Psychopharm states, but they don't have a reference for this, but I'll put it out here, and it may make some sense. They say that when you're treating panic disorder with benzodiazepines, it's not rare to need to up-titrate a couple times, modest up-titrations over 2 or 3 months. They're careful to add, this doesn't mean a forever up-escalation of it. It's just 2 to 3 times to get the treatment maximized, and then the people stay put. They shouldn't continue up-titrating endlessly. Other anxiety disorders, these agents can be effective in GAD. You may have looked at this study from January in the American Journal of Psychiatry. It was nicely done. Some people called it a landmark article in anxiety treatment. They took folks who had social anxiety disorder, gave them a 10-week trial of a reasonable dose of sertraline. Those who did not respond then got randomized to either sertraline plus placebo, venlafaxine, a switch, or sertraline plus clonazepam. And the study showed that in the placebo, sertraline placebo versus clonazepam, there were statistically significant differences on measures of social anxiety. Venlafaxine fell in between, so it didn't separate out, but numerically there's obviously an improvement there that runs along the same course. These were the doses of the agent. Clonazepam was dosed, the mean dose was 2.3 milligrams a day. Regarding benzodiazepines for PTSD, the VA has taken a stance against this on their website. As far as PTSD treatments, they recommend against it, in part because they're concerned that it could inhibit the benefit or limit the benefits of exposure therapy. And another cartoon, we see this gentleman, he's already gone past the Valium Bowl. And he's sitting in the back, he's a financial planner or investor, and he's saying, jitters about the economy, I can safely say that is not a problem at our company. Now, for those of us who even have retirement on the horizon, we're all hoping that that isn't what's going on with our investment counselors, I'm sure. Some fine points related to benzodiazepine prescribing. This prescription is a problem, potentially, if a person's to be maintained on the agent for the long term. And this is not, it's not rare to see a prescription like this. It's a problem because the person will have a lot of anxiety. They'll be up-titrated to 1 TID of Alprazolam. 2 months out, they'll say, hey, this is as needed. I'm doing pretty well. So I think I'll stop it, or I think I'll decrease it. And they'll have an impressive reaction, almost certainly, and it will then convince them that they need Alprazolam forevermore. more than likely. And so many people have said in the office, you know, I know that I need this drug because I stopped it once. And boy, was I uncomfortable. Yeah. So we either give it as a fixed dose and then taper it later, or maybe a once daily PRN at a low dose, like after a panic attack, which leads me to this. PRN benzos are, for panic attacks, are inappropriate. Many people feel that once they have a panic attack, their day is wrecked. So yes, it's true from a pharmacokinetic perspective, when you give an agent, it's going to take 30 minutes to an hour to really kick in. You're not going to get at the panic attack, but you're going to help them sort of rescue the rest of their day in very reliable patients. And this comes up from time to time, a note saying, I told the patient to try to take less benzodiazepine when they're physiologically tolerant. We really want to document how much we ask them to decrease it, you know. Because otherwise, they're just not going to be that sophisticated to be able to do it in a safe way. In terms of the taper intolerance, a Cochrane review said a 10-week taper. The APA textbook of Psychopharm says about 0.5 milligrams every 2 to 3 weeks for high-potent agents, Alprazolam and Clobazam. Personally, I like to go 0.25 a week because I've had people insist that they saw the difference with the 0.5. I've never heard a complaint about that other type of approach. Everyone has their favorite. Studies have suggested that CBT interventions with gradual dose reduction are the most effective way to taper. This is, I'll just very briefly describe this. This is a study from Australia, and they did a clever thing. They came out with recommendations. And this is about benzodiazepine sleepers, actually. And they said, we'd like for the prescribers to begin decreasing. They set out educational materials to physicians and so on. Then they picked out one area of the country, and they did an intensive intervention. They sent them specific treatment guidelines. They did a media campaign out in the community. They gave the patient educational materials. And they found that when they went back and looked at the country as a whole, or the group that was not the country without the intervention group versus the intervention group, the country decreased the prescribing rate by 6% and the area of special focus by 19%. So that type of an intervention to try to adjust local culture was effective. I mean, that's obviously what our state health folks are trying to do in Tennessee right now with opioids. They're trying to evolve the culture a bit. Are all benzodiazepines the same? This could be controversial. 1,5-benzodiazepines, so-called again because Clobazam has a nitrogen 1 in 5 position. And there is some thinking that Clobazam preferentially binds the alpha-2 subunit, which is the anxiolytic area on the GABA-A receptor, and whereas the alpha-1 subunit is hypnotic. So some thinking is you could get less sedation with more anxiolysis with agents like Clobazam. I think Clobazam is available in Canada and some other countries. It's available in this country for the treatment of seizures. Are triazolobenzodiazepines antidepressant? Going back to Alprazolam again. So there was an early clinical literature that compared this to the TCAs. And in some of these studies, the TCA doses actually were therapeutic. I think one of them, imipramine level, was around 177 as a mean dose. That's respectable. And it did show that Xanax, Alprazolam, was helpful for depression. There are lab studies using old models, depression models, both in behaving and anesthetized rats, which showed that they had some of the profiles of antidepressants, that is specifically Alprazolam. And there's one study that showed an upregulation of serotonin with, it may have been adnazolam, another triazolobenzodiazepine, or I can't recall if it was Alprazolam or adnazolam. Anyway, it upregulated serotonin, but diazepam did not. Now, and then in 2012, there was a Cochrane review that indicated there is moderate evidence for an antidepressant effect with Alprazolam. Now, I'm not suggesting it's an antidepressant, and I'm not going to use this agent as an antidepressant. But what interested me about it is I'd always been curious because it seemed to me that, even factoring in the pharmacokinetic issues and the short half-life of Alprazolam, I couldn't make sense of some folks who had a terrible time getting off of it or being cross-tapered to another agent. And I wonder if some people really do see some effect like this. That's what aggravates handling the med or tapering it. I don't know. I don't have proof of that. But I've always wondered about it. For me, Alprazolam has been the most difficult benzodiazepine to manage, which makes the fact that it's the leading prescribed one all the more concerning. Here, Herman identified in '87, wrote about clock watching because of its short half-life, and this having to do with heightened anxiety, dose escalations. Many people refer to these between-dose anxiety breakthroughs as mini withdrawals even. Now, a few comments about initiating benzodiazepines. If we go to the literature to ground us with these agents, we want to identify the anxiety disorder. We have all these other disorders. We have anxiety disorder NOS, an unspecified anxiety disorder. Those are okay, but we don't have a literature to guide us in how to treat them. So if we can parse that out and refine our diagnosis, that might be helpful. Generally, for me, I see them as second to third line agents. There's a debate in letters to the editor in the American Journal of Psychiatry after that article about social anxiety disorder in January. In July, someone wrote a letter to the editor complaining about the study, noticing that it should have just had a benzo-only arm. And then the author wrote back about it going back and forth. The short of it is, it seems like the opinion still is that they're second and third line agents in people for whom SSRIs, SNRIs, other interventions just prove inadequate or only partially adequate. And then you're still factoring issues of substance use. They have a substance use history, are they in remission? And especially, are they in sobriety maintenance? Have they worked the 12 steps in their respective disorder, for example? Do they have a sponsor? Are they a sponsor? Another thing to think about, and I know this is obvious, but having seen people that I treated who were on benzodiazepines who were consuming 1 to 2 grams of caffeine a day, that is, they had ongoing caffeine intoxication, it's always worth reviewing. And of course, look at the medical issues: sleep apnea, opiate prescriptions, COPD, so on and so forth. Consider getting a baseline urine drug screen on anyone. For me personally, I tell every patient I give a controlled substance to, this is a part of your treatment. It's an expectation that I monitor this. It's a state law that I am careful about it. And so I bring that into the interaction on the front end so that later on, if we have to go to that or if we choose to go to it, it's already been covered a bit. And I would think a UDS is necessary in people in recovery if you're thinking to use this agent. And so informed consent about risk of cognitive problems and so on. If we're giving these agents in the up-titration of the SSRI, I think those studies ran out, about 3 weeks, where they would give the benzodiazepine and then add in and then taper them off of it as the SSRI began to have effect. Certainly no more than 3 weeks, because it's around that time people can develop physiologic tolerance. So we don't want to have that as a run-on if that's why we're using it. And if long-term, we continually reassess. Now, know your urine drug screen, because every urine drug screen has a different pattern. There's no, we were on the phone on Monday, Don Henson and I, we worked together in Buprenorphine clinic. We were on the phone Monday with the science officer talking about our urine drug screen at the VA. And it turns out that there's no perfect one for picking up benzodiazepine. And most of them are fairly poor for clonazepam. They're limited. On one drug screen we have at the VA, for example, diazepam's very easily detected. Alprazolam also, not quite as well, but pretty good. Clonazepam less likely. You almost will not detect lorazepam with that drug screen. We have another drug screen at the VA that will pick up lorazepam very well. So it's really useful to know the behaviors of these tests. And always consider buprenorphine screening because it's usually not tested for, and increasingly it's a substance of misuse. It goes without saying that psychotherapy fits into anxiety disorders always. And whether we're formally referring to a colleague or doing the psychotherapy yourself, or however we're doing it, medications don't reconstitute daily habits in and of themselves. People need guidance at a minimum anyway, and perhaps ongoing psychotherapy. And I never give a talk on anxiety without mentioning meditation. And we know the old literature that showed that it improves stress, blood pressure, cortisol, and other areas. But now we know that it generates neuroplastic brain changes. That's being documented, helps with attention, self-efficacy. This is just one slide. I could put up several of studies that showed an increase of gray matter associated with meditation. This is a study from July in the American Journal of Psychiatry showing improved resiliency in high-risk individuals. That is, Marines getting ready for deployment. There's another study that came out in the past year that showed that for those who were randomized to mindfulness, they maintained executive functioning better under pressure than those who had not. And there is a literature about meditation. This is a meta-analysis from earlier this year, which in this analysis, they started out taking a look at almost 19,000 papers on meditation, or some form of it. So there is a literature. Some of it's quite good, and more of it's coming out all the time. It's the kind of thing where we can introduce our patient to following their breath and using that a few minutes a day in 5 minutes in the office, and then just keep on helping them develop it over time. Some patients never take to it, but it's surprising that some come back with just a few-minute intervention, and they're up to 20 minutes a day and really seeing benefit. So I come to the end now. No clinical psychopharm talk occurs in a vacuum. And I want to acknowledge my team members from the VA on Team 3. We've had a lot of discussion about these issues, and in fact, they usually give me helpful feedback. We review my talks ahead of time. I really appreciate that. And then the folks I work with in the Buprenorphine Clinic, Don Henson and Pam Hallett and Dr. Rodriguez. Don and I have done a lot of work together lately just taking a look at urine drug screens and such. And so with that, I will stop and welcome questions or comments, personal experiences. Do we want to use the... I'm not sure how to... I don't know if the mic's coming through. Is it on? That way there are folks by video.
Oh, there we go. You got it.
That's it.
So I've been out in the community
Yeah.
since 1992. I graduated from medical school and from residency here. And one of the things that I think would be really nice to know is that some people get a great benzo effect by having the prescription in their pocket and never filling it. And a lot of that seems to have to do with their confidence that this drug will work for them in a crisis, but they don't need to use it because they have access. So there's a lot of that kind of teaching that I find useful as well.
Yes, thank you for the comment. And it is noted in the literature. Thank you.
Comment and then a question. The comment goes back to your slide showing the co-administration rate of benzos and opiates. And this comment is based on about 25 years I spent as a consultant for the Social Security Administration reviewing comprehensive sets of records for patients applying for disability benefits. There was a lot of co-administration of benzos and opiates in those records, but it was a bimodal distribution in the sense that there were some clinics where it was virtually 100%, and there were other clinics where it hardly ever happened. So
And it was this, I'm sorry again, was this in Tennessee?
Yes, this was here.
Okay.
So I think the 20 to 50% figure obscures what is really a polarized practice environment, and patients in the community very quickly figure out where they need to go to get the combination. You know, and they walk in the door, and this may be a slight overstatement, but my impression is that the prescriptions were pre-written. The question is, are there any accepted protocols for rapid detoxification
And when you say,
from benzos?
when you say rapid, what?
Well, as you talked about the 5 milligrams per week
Right,
taper.
right.
I consulted on a case not too long ago where somebody got in real trouble going from 6 milligrams of Klonopin a day to 0 in 2 days.
Yeah, that's a problem.
Yes, it is. And one of the questions that came up in that case is there anywhere, has anybody ever offered a model for rapid detoxification? I couldn't find one, but I'm just curious as to whether you know of anything.
Well, you know, I think that actually, I don't know about the surrounding community because I haven't worked in other areas or covered inpatient. But I think that the inpatient unit, E2, deals with this fairly regularly, whether it be a mix of opiates with benzodiazepines, and alcohol works at the GABA receptor, although it works at other areas too. So to my mind, you could model after that, but they give a taper depending, and then they watch how it goes because it may have to be delayed. I mean, Klonopin 6 milligrams a day, you're not going to get them off, as you said, obviously in 2 days, maybe not in 5 or 6 days. But they're able to put people a lot of times on a 40 QID dose of Valium with this long half-life, and then walk it down even as rapidly as 10 milligrams a day, and covering for breakthrough with alcohol or even opioid benzodiazepine codependence. But obviously, you'd have to make adjustments for a dose that great. Thank you. Other questions, comments?
Thanks, Dr. Griffith. That was really excellent review. I don't know if you saw, a study came out a couple years ago that was a review study, and they looked at the old adage of start with the benzo, and then while an SSRI level builds up, and taper them off.
Right.
And my personal experience, but it was not based on any data, was that people don't taper off. Once they get on the benzo, an SSRI is just not the same. It's just not. It feels different.
Right.
And so my personal experience was don't do that if at all possible because you may have a problem. And what the review found is that even though people were trying to go by that adage, they never took them off because the patient didn't want to come off. So I just wondered, you know, if you saw that, and also what do you think about that in terms of?
Actually, relevant to this, I saw a person just this morning where this issue came up, and it's related to it. In that it's a young man, he's having 2 panic attacks a day, and he has no history of substance misuse at all, nothing in his family, it's clean that way. And it's interesting because I switched him over to a slow-up titration of paroxetine, and I broached the subject with him. You know, should we consider a benzodiazepine for 2 to 3 weeks? I told him about the possible cognitive effects and the possible development of tolerance. He said, I'll give you a call. He didn't want it, you know. So, you know, I just say that because a lot of times there's the thinking that people are. On the other hand, I run into this constantly. I'm sure we all do in clinic. You know, sort of sarcastically, I refer to it as missing the halcyon days. Although halcyon was a sleeper, it's still a benzo. And it's longing for the I have people in Suboxone clinic who are never going to get a benzodiazepine from me saying, you know, they'll just sit. I have one person who just looks off into the distance and begins to think about when he had clonazepam, 1 milligram twice a day in the other Suboxone clinic. And, you know, but in fairness, it is different. There's no question about it. And maybe there are some people who really benefit from benzodiazepines and will do well with them long term. But I follow you. There are the studies that show that once they do this, they tend to continue them. And to my mind, you have to have a very firm understanding that you're not.
And I think those control freak people, the ones that are like, I don't want to be clouded, are the most risk, at least in my
Yeah.
personal, again, not based on data. But the people that want it, of course, are the highest risk, and there's a whole bunch, there's an increased risk with panic disorder of substance.
Yes.
So then we know that high tolerance, people with panic disorder, for Benzos, so there's a lot of negatives in that respect.
And another thing, although we have a few more studies out, when in 2010 I started really digging into the literature here, that surprised me is that there isn't that much written about benzodiazepines. You have the early studies where they did the up titrations to 6 of Xanax, and you have some where they're beginning to come back and look at it, like the nice study in January in the American Journal, but there isn't that much. Yeah. And I haven't seen, I went looking for it, but it's been a year or two. I haven't seen functional imaging studies that have specifically tried to take a look at this and correlate it with psychological testing. There is the testing, but I haven't seen those correlated. I've looked for it in other studies where they looked at the imaging as they were getting ready to do another trial on top of it. They were using it as a sedative in the scanner, but there's not enough there to extrapolate it. Yeah. Thank you. Other comments?
Thank you for coming.
Good to see you.
That was the last presentation.
That was fun.